Good morning, good afternoon, good evening, everyone. It gives me a great pleasure to welcome you here today for the third of the Partnership for Maternal, Newborn and Child Health Policy Dialogue Series branded as Ready, Set, Implement, focusing today on improving financing to reduce mortality of women, children, and adolescents and leveraging the benefits for societies. Today's discussion builds on the renewed global commitment encapsulated by the 77th World Health Assembly Resolution on Maternal, Newborn, and Child Health, adopted earlier this year, and calling for accelerated progress in reducing maternal, newborn, and child mortality. It is completely unacceptable and, quite frankly, astonishing that today the leading causes of maternal, child, and adolescent mortality are largely treatable. And yet, these areas remain critically underfunded and under-resourced. Instances of postpartum hemorrhage and infections continue to drive high maternal mortality rates globally. Almost 1 million children under 5 die from preterm birth-related causes annually, and adolescent pregnancy-related complications and unsafe abortions remain the leading cause of death of girls aged 15 to 19. The scale of challenges require bold, collective action that is rooted in robust investments across the continuum. Without stronger and better financing, the aspiration enshrined in the global development agendas will simply remain out of reach for the many being left behind. We know that the investments needed are achievable and offer solutions that have long-term and multi-generational impacts on the wealth and well-being of women, children, and adolescents. For 74 high-burden countries, every US dollar spent on key investments for reproductive, maternal, newborn, and child health would give a return of up to $20 in economic and social benefits by 2035. Yet we are witnessing a rollback on these critical investments. Official development assistance flows for reproductive, maternal, newborn, and child health interventions, which were already decreasing prior to COVID-19, fell further by 14% from US $6.2 billion to US $5.3 billion between 2019 and 2021. The reality today is that the cost of inaction is simply too high to ignore. For adolescents alone, the average cost of inaction has been estimated at 4.1 trillion US dollars per year between 2024 and 2050. The dialogue today brings together a very prestigious set of experts and leaders from across the world to focus on practical strategies needed to leverage investments in women, children, and adolescent health and well-being. We will be hearing from them shortly from the experiences of those implementing innovative mechanisms such as intersectoral financing and public-private financing. I urge those of you here today to engage actively in this important and timely conversation to advance stronger and smarter financing models, progress in women, children, and adolescents' health, as well as realization of 2030 agenda is simply impossible without the required investments. I really thank you for being today and taking your time out to join us for this discussion and look forward to having a conversation with you all. And with that, I would like to invite first Honorable Dr. Jalikatu Mustafa, the Deputy Minister for Ministry of Health and Sanitation from Sierra Leone, to share her keynote reflections. Over to you, Dr. Mustafa.
Thank you very much, Rajat, and thank you for that summarizing the issues of why we're here in your opening statement. Good afternoon or good morning, wherever you are, colleagues, partners, health champions from all over the world. It is really my pleasure and honor to today. First of all, apologies from the Honorable Minister, Dr. Dembi, who would have loved to be here instead. But I'm happy, very happy to take his place. We're
Dr.
here
Mustafa, your
today
connection seems to
to
be losing.
reaffirm our shared commitment to the health and
Dr. Mustafa, sorry
survival
to
of
interrupt you, but the connection
women
seems to
and
be
our
very poor.
communities and our societies. Despite the reminder, we have women losing their lives.
We seem to be having a connection problem with Dr. Mustafa, as you would all have heard. She's calling us from Freetown, Sierra Leone. We will be working on fixing the connection problem, and maybe we can have her join us later in the conversation. But we do have, our entire panel is already with us, and maybe I will take the advantage of the panel being with us and dive into the panel discussion and invite Dr. Mustafa to share her reflections to the end of the panel discussion. And it's my great pleasure to introduce the panelists that we have with us, starting with Dr. Anya Soukar, Director of Health and Social Protection for AFD France. We are also joined by Dr. Olusoje Adeye, President of Resilient Health Systems, Dr. Mehraika Winkroff, Head of Strategic Investment and Impact Division at Global Fund, and Dr. Flavia Bustreo, Vice President, Fondation Botnar. I'm very, very pleased to have you all with us, and thank you so much for joining us. And maybe I can start with you, Agnes, and with a question in terms of where do you see the opportunities to advance innovative financing and co-financing models within the context of women, children, and adolescent health? Over to you, Agnes.
Thank you very much, Rajat, and thanks again for your leadership on the PMNCH agenda, as well as more broadly in this discussion about financing for health. And as a financing person or expert, it's always been for me an inspiration to see how this community has championed approaches that have mobilized both public and private resources for the objectives of women's, children, adolescent health, and has helped over the past century, I would say, develop this kind of approaches. And I really want to start within that with what has been the foundation of the financing for women and children, which is the twinning of financing for health and financing social protection. It's always been identified that the issue of women's health and children's health, and now adolescents, is very much linked to the question of vulnerabilities and poverty. And that the whole history of maternal and child health has been a history of how to redress inequalities and how to not only provide services that are accessible and affordable, but also address the demand barriers and integrate demand side financing together with supply side financing. And I think more than ever, this is the new MCH in a way. That this lesson needs to be brought about at the forefront again in the post-COVID era, because we've observed during the COVID crisis that the kind of approaches that transfers directly funds to a vulnerable population is extremely powerful. It's powerful as a crisis response to support vulnerable households. It's powerful as a counter-cyclical investments when it comes to an economic shock and a social shock. And one of the real successes of the response to COVID has been the mobilization of safety nets programs and cash transfers programs, been quite well documented, and including by a report from the World Bank. And we've seen all countries really responding. It's already, and as you know, Soji is here today, and we published a paper a couple of years ago that showed that in 2020, in fact, the response to the pandemic happened at country level first. And I think that's really the lesson of mobilizing financing that is directly directly targeted to the vulnerables, and first mobilizing domestic funding. Two other lessons, very, very rapidly. The second one, I would say, is the focus on high impact interventions, which is a very much also a message that has primarily originated from this community. And when I think I'm old enough to remember Gobi FFF from UNICEF and James Grant, is like identifying what works and working on disseminating technologies. And here I refer to the latest report, the Lancet Commission 2050 on global health. And Flavia was also part of this, in promoting the messages that are brought forward by PMNCH. And the message of the Commission is very clear. There are 15 areas, 15 sets of interventions that can help divide the probability of premature mortality by half by 2050. So this message of we have low-cost technologies that are still insufficiently disseminated and need to reach the poorest and the most vulnerable is an extremely, again, a new old message, but with more evidence, more science, more technology also, new vaccines, new medicines, new approaches. Also, not only medical technologies, but also information technologies, the dissemination of information through the different means and access to information today, particularly of young population, information and education. So that message of there are technologies that make the difference, and combined with the first message on demand-side financing, can be extremely powerful, like transferring funding directly to people and disseminating technologies. And I'll finish with the third one, which I think is a key message for the future, which is better using the fiscal instruments. And that's also a message from the Lancet Commission 2050, which is that we have, in fact, modern state is something very recent. Modern state has been born at the end of the 19th century. But what is new is with digitalization, now we have increasingly data, and we have more and more evidence about what works and what doesn't work in terms of public policy. And if there is one thing that we increasingly have documented, is the role of taxes and subsidies on public policies. And we know some of them are actually harmful. Again, a report from the World Bank from last year on harmful subsidies, that is public money going to the wrong thing. So in fact, it costs a lot of money to do the wrong thing, like subsidizing fossil fuels that contribute to air pollution and the death of children, as well as to climate change and its related effect on health. But also taxation in the terms of health taxes. And we know for adolescents, for example, that tobacco taxation is extremely powerful, associated with messages on information, neutral packages, and so on, is extremely powerful in reducing the risk of adolescents to enter into a cycle of addiction to tobacco and the very serious health effects of tobacco. Actually, one of the message of the Lancet Commission was tobacco is the new tobacco. And I think when it's a message about adolescents, it's a very important one to say. But it's the same, these health taxes. Now we know the effect also on alcohol of these health taxes. And now the very promising area of taxation of sweetened beverages and beyond. This is actually happening in the context of the fiscal crisis in France right now, in which really the taxation of sugar more broadly can be seen as a win-win-win. It's really reducing the risk of obesity, in particularly among children and adolescents, but also bringing more money into the coffers that can be used for social protection. And here I sort of close the circle that I started with my first point. Thanks.
Thank you. Thank you so much for that, Agnes, and really laying it out in three very, very concrete steps. And before I do come to you, Dr. Soji, for your reflections, and I was laughing with Agnes a few days ago, the dialogue between the two of you on some of these issues have been so much of a learning for the wider global health community. So would be very much welcoming your remarks on that. But also two quick points before handing it over to you to share your preliminary reflections. One, we do have Dr. Mustafa back with us. There are some technology issues. Dr. Mustafa, we will come to you at the end of the panel discussion, so do bear with us for a few minutes. And maybe we will go without camera so to help with the bandwidth issues. Second is to our esteemed attendees for this webinar, please do get your questions ready. This is a very formidable panel of experts, hard to get together. So do please get your questions ready so that we can come to them very swiftly in the next few minutes. And my colleagues from the partnership are sharing with you some of the resources in the chat function to what some of our panelists are speaking to. With that, over to you, Dr. Soji. Very much looking forward to hearing your views in terms of what can be done to support equity-enhancing investments, particularly targeting women, children, and adolescent health. Over to you.
Thanks, Rajat, and I want to thank you very much and your colleagues for the opportunity to serve on this panel and learn along with everybody. It's always a challenge and a pleasure to follow my good friend Agnes. So I'm going to build on what she said, with which I agree entirely. And if we're looking at equity enhancing investments there, at the risk of being picky, want to note that we've loaded two very interesting words there. The first one is equity, which implies, however you cut it, a disproportionate focus or emphasis on those who currently are underserved or underreached. And second, the concept of investment, which means in classic terms, if you put in $1 today, the only rational reason you do, the only rational basis for doing it is because you expect to reap more than $1 down the road, all other things being equal. Let's keep those two in mind. So if we start out from health services and then we broaden out, well, the classic necessity is ensuring effective coverage for those who currently, those women, those adolescents, those children who currently have comparatively low coverage of quality assured services or poorer outcomes. And that has to do with the configuration of services. It has to do with a willingness to recognize and work with the private sector that delivers the bulk of those services, or at least a large portion of those services. Because still up to today, a good chunk of the global health sorority and fraternity is reluctant to work at scale through that private sector. And I think that's not a wise thing at all. But the supply side itself is not enough. And so I'm going to pivot somewhat outside the health sector per se to look at a investments outside the health sector that have tremendous health benefits, both in the short, medium, and the long run. So starting with education, which is emphasizing but not limited to education of girls. That's crucial for obvious reasons, some of which are the literacy that comes with it, the preparation for the job market that comes with it, the delayed initiation of childbearing that comes with it. All of those are beneficial. And so it's in the interest of the health sector to proactively engage with the education sector. In fact, $1 spent in the education sector is going to benefit health outcomes, all other things being equal. A second one is labor force participation. That's female labor force participation. Because of the relative independence that it grants, the benefits of which are vast, and these are in the publicly available literature. A third one is financial inclusion, or if you like, access to banking services. And that could be tied very neatly into a set of programs that draw on lines of credit without requiring those women to have traditional collaterals. Because in a sense, it frees them up from being dependent on their partners for those lines of credit, which is a very important part of the decision-making as a tool for empowerment in a construct in which you're seeking to improve equity. Now, we use the word for investment. So I want to dwell on that for a moment. And that is at the risk of sounding a somewhat discordant note on a Monday morning. It's still morning here in Washington, D.C., from where I speak, which is, I think the word investment is frequently abused in PMNCH circles and in global health in general, because quite often it is a cover for let's just raise money and throw it at the problem and do the same old things in the same old way. And my sense of it is that there are some preconditions that need to exist for those investments to bear fruit the way they are intended to. One is pin-sharp clarity of purpose. That is often not there. Instead, it is put in very mushy terms, and let's go out and seek replenishment because women and children are dying. A second one is disciplined allocation of resources. I think we probably want to be a little more self-disciplined in the criteria by which resources are allocated. And Agnes already drew attention to the recent report of the Commission on Investing in Health, Global Health 2050. So I will not repeat those. A third aspect, and I think this is one that needs continued and clear reflection, is the way in which the current architecture of development assistance for health itself undermines disciplined and optimal investment. If you push the discussion, I would say it would be a good day when we had fewer actors in the financing of PMNCH, i.e. external actors. We need fewer, not more, okay? And we also need the current large actors in financing to have explicit exit dates, because not having an explicit exit date sets up perverse incentives for those financiers, and it sets up perverse incentives for the countries themselves, or at least for a number of the countries themselves. These are not, shall we say, they might not be easy discussions to have, but they are essential discussions to have. So overall, I think that the opportunities are there. Many of the things that need to be done to support equity enhancing investments are really not new, okay? And finally, I think it's important for the external financiers to look in the mirror and see what they can do differently, just as it is essential, absolutely essential, for the countries themselves to take more responsibility for financing and organizing with domestic resources those equity enhancing investments. Back to you.
Thank you so much, Dr. Soji. That was very inspiring, and I do have to say, a lot there to unpack. And I do hope the panel and our audiences will dive into some of the issues that you made, both in terms of the emphasis and how you looked at issues of equity enhancing, and also what the funders, the investors of these agendas need to do differently, and bringing in a lot of food for thought. Without much further ado, I would like to move on to you, Marika, and for your reflections on how can we leverage innovative financing for women, children, and adolescent health. Over to you.
Thank you very much, Raja. Good question, and also really pleased with previous interventions by Agnes and Soji, and references to the Lancet 2050 report, which I think is really key. I think sometimes we look at innovative financing as like a magic pot of money that we can pull out. So I would like to put it a little bit into context, and also would like to provide a little background on the Global Fund, how we are funding women's and children's health and adolescent health. 10-15 years ago, the Global Fund did an analysis. It was before I joined, it must be 15 years ago, on what percentage of Global Fund funding goes to programs that specifically benefit women, children, and adolescents. It was at that time 46%, so very significant. And if I look at the additional investment we are making now in health systems, including on human resources for health and community health workers, on community rights and gender, with much more focus on gender in the programs we're supporting, increased focus on HIV prevention, I think it's going to be much higher than 46%. So even though sometimes people look at the Global Fund as somewhat apart from the MNCH community, be really a big funder in this space. Then if I want to put innovative financing into sort of a broader context, is one tool that we have in our toolbox to improve the way we raise resources for health, and building on the point that Soji made, it was ending with. I think we really should start at the work that we're doing with governments, with Ministry of Health and Ministry of Finance, and how can we get more money for health. That does include working with, especially Ministry of Finance, on public finance management, including the role of supreme audit institutions, so that increasingly we can rely on the national systems to manage the funding. It also means to work with countries, Ministry of Health and Finance, again, to incentivize increases in domestic resources from the government in health and in infectious diseases, but also more broadly into health system strengthening. And the board in November approved a new policy on sustainability, transition, and co-financing, where we want to further work with countries to increase domestic resources for health, but also have much more engagement and discussion on how the money is spent, about programs the country is investing in to increase sustainability. And the last thing we're doing to increase sort of the money that is available for health is the advocacy, working with the African Union, the African Leaders Meeting, the NEPAD, and the regional economic commissions in Africa to really work on national, or support the organization of national health dialogues, where all the different actors are coming together to have a discussion about domestic resources for health. So that's more health for that's more money for health. Of course, we also have to work on more health for the money. And I think, Agnes, you talked about the high impact interventions, absolutely. Also increasingly focusing on value for money. So how do we make sure that the areas we're investing in with increasingly tight resource envelope, how do we make sure that we maximize the impact of the collective investment we're making? And then as an additional tool, we do have innovative financing. For the Global Fund, we have at the moment two key tools for innovative financing. One is debt to health. It's where a country, a debitor country, provides debt relief with a commitment from the country that they will spend the debt repayment, the money that they otherwise would have spent on debt repayments, to invest in public health programs. Germany has been a key country that has been active in debt to health and providing debt relief to countries. And sometimes those are really significant amounts of money. We recently approved a debt relief, a debt to health grant for Indonesia of $65 million, which goes to infectious diseases program, mostly TB, given the huge TB burden in Indonesia, but also the health system strengthening. So that's an important source of funding. And then, of course, we do blended finance deals for the, yes, in depth with a B, blended finance deals. I know there's a lot of different definitions of blended finance. For the Global Fund, it really means that we combine our grant funding with the funding from multilateral development banks or other financial institutions. So far, it mostly has been with the World Bank, but also recently we pre-qualified the Asian Development Bank for blended finance deals. Where sometimes it's like in India, we had a loan buy down, where the country has, so we can improve the conditions for the loan to the country based on disbursement linked indicators. So if they achieve certain results, the conditions of the loan will be lighter, more favorable. But also we have in certain countries, we blend financing with multilateral development banks so that we can leverage additional funding for health and then include disbursement linked indicators on areas that are important for health system strengthening, that can be important, that are important for infectious diseases programs, but also can be important for the programs that target most vulnerable populations, which normally would not be a priority of a loan from one of the multilateral development banks, but that way, through the blending, we can steer those interventions. Maybe I stop here, Rajat, and we can further discuss after we finish, if we get to the QA session. Thank you.
Thank you indeed, Marika, and lots there to unpack indeed in context of innovative financing, and really appreciate the points that you made about domestic resource mobilization, debt relief, and what more needs to be done in terms of leveraging resources and making sure that they do reach those hardest to reach. And indeed, we will come back to the panelists with the second round of questions and for their brief reflections. To carry on the discussion, and certainly last but not the least, coming to you, Flavia, for your initial reflections on how can we address the financing gap for women, children, and adolescents' health across the life course, and what do you think some of the learnings are that we need to take into account as we move forward? Over to you.
Thank you, Rajat, and I have to say it's a real pleasure and a delight to be in the panel with distinguished and esteemed colleagues I've worked with a long time, including at the World Bank. So I'm delighted to be in the panel with you, Agnes, and Soji, and Marike. I want to make 3 points in relation to the question on addressing the gaps. The first point is all the different mechanisms that we have discussed so far, they have not been designed or specifically address adolescent health and well-being. And they, as Agnes alluded, the cash transfer for experience, for example, was really developed with children and pregnant women in mind. And yet, adolescents constitute 16% of the world population, and this is a demographic that has been historically overlooked and to some extent misunderstood. So one thing when we look at the gap, Rajat, is important that we ensure that investment in the early years, they are not lost. And as we published in the adolescent investment case that was launched earlier this year by PMNCH, spearheaded by the Knowledge and Evidence Working Group and the great work of our esteemed colleague, Professor Sheehan and Rasmussen, the socioeconomic returns of investing in adolescents are high, are equally high as in the early part of the continuum. And therefore, investment in adolescent services, HPV vaccination, TB control, prevention of child marriage, road accident prevention, education and training, all of these investments are key for adolescent health and well-being. And most staggering here is considering that there is a huge cost of inaction for countries that do not make those investments. And you quoted that, Rajat, at the beginning of this conversation, that is estimated at 4 trillion per year in the countries that were part of the analysis, around 7.7% of the GDP of those countries. And over the period of 24 to 2050 is $110 trillion. So this is my first point. Of all the continuum and the population that we are focusing on, this is one that needs particular care. The second point I'd like to make is the issue of the overall quantum of financing. I use these words particularly because it was very used in the climate negotiation last month. So the quantum, I mean the quantity of financing that is through the domestic financing and the external ODA financing with all the different mechanisms that exist. And the fragmentation of those mechanisms. Because as all colleagues here in this call and the panelists that have preceded me, we have wonderful experience with Gavi, addressing the immunization needs, including HPV, for example, for adolescent health. Of course, the Global Fund and the huge investment that Marika alluded to for addressing malaria, TB, HIV, and all the health system investment. And then, of course, we have the Global Financing Facility for every woman, every child, and every adolescent, which can leverage IDA funds. But the GFF, in addition to being more recent, also at the moment addresses only 54 most poorest countries in the world. So quantum and fragmentation of the financing is my point. And then the third point I like to make is, this was already touched also by Agnes, and maybe I would like to build on her point. And also Soji spoke about that. It's a balance between domestic financing and external financing. And clearly, domestic financing is key for sustainability. And here, some of the suggestions that I like to make, in addition to what they have already proposed, for example, the clear suggestion that has come on the Lancet Commission on investing in health, that is the use of tobacco taxation to increase the revenues the country have. And this was defined by our commission as the intersectoral policy tool for domestic financing, which is the most underused and still underused in many, many countries. And as Agnes elucidated, has a lot of benefits for example, adolescents and health over the life course. But there is one domain that I like to explore more and make more on my points in terms of the external financing that can be accrued. And that is the intersection between health and climate change financing. So this intersection is critical. Number one, because we know that the women, children, and adolescents are actually most impacted by the global climate change. I don't have time to elaborate on that part, but we know that. We have documented that. And yet, despite that, only 2.4% of the financing from the Multilateral Climate Fund supports projects that incorporate, for example, responses to climate change and climate hazard. So there is a large opportunity here to work with the climate financing in order to accrue what we call co-benefits of co-financing. And maybe in the second part, I will explain more, Rajat, how some of those opportunities can unfold. Let me stop here.
Thank you very much for that, Flavia, and remarkable, really, how you have brought together the points about the quantum fragmentation, but also the intersectionality and linking the climate and health financing agenda and bringing these issues out. I do come back to the panel now. I have a follow-up question, and there is a lot. Please do feel free. And my request to all the panelists, in case you heard something that you want to react to, please do feel free to pick up that in your responses as well. But if I could ask a common question to both you, Agnes, and to you, Soji, and something that you have already talked about, and something that within the global health space and different conversation is very ripe, looking at the Lusaka agenda and its implementation, and how do you think the investors need to align financing with the unique country needs, and what do you think it will take for us to really come into those conversations and address the kind of challenges that we do need to address when we think about issues on alignment and financing and implementation? And maybe I start with you, Agnes, and then I go to Soji, and then I come to Marika and to Flavia for the different questions I have for them. Over to you.
Thanks, Rajat, and thanks for the question, because I think when one sits like I do in a donor government agency, right now there are a lot of questions about the future of global health and its financing, and we really see this sort of tunnel of replenishments coming for all the different agencies. And of course, there are a lot of questions, and those questions, of course, arise in a macro economic context, in a geopolitical context that is very rapidly evolving, both post-COVID, but also post-Ukraine, now with the conflict in the Middle East, and frankly, with the rise of the now increasingly emerging question of adaptation to climate change, which is really brought forward by developing countries. And you followed what happened in Baku, with a very firm position from the countries of the African Union about loss and damages. And this is a very thought through, strong position of EU countries about this need for compensation in investments for something so radical that happens to them that they did not contribute to, because they did not contribute to climate change and fossil fuel emissions. But they are, as we know from some of the work sponsored also by PMNCH, particularly the work in Pakistan. I'm thinking of the publication of Zulfi, and is that there is really this increasingly questioning of whether we have the correct, appropriate ecosystems for global health. This ecosystem has been built over the past 20-25 years. It responded first to a question of emerging epidemic. It was the HIV epidemic. Was expanded to some really critical epidemics that are global epidemics that are causing a lot of mortality, tuberculosis and malaria, and there were different types of mechanisms were created that were both bilateral, like PEPFAR, and multilateral, like the Global Fund, and of course the funding of maternal and child health through mostly Gavi, and after that the GFF. But if we observe what has happened, we've sort of seen a mushrooming of mechanism over time. And it's been very well documented. Actually, a less known publication of the World Bank recently that shows actually how the number of global health organizations and partnerships has multiplied recently, either by creating new organizations or by splitting existing organizations into different areas. And none of these new mechanisms get ever closed, but new ones keep emerging. And I think in a way, COVID has shown the limitation of that, first by as we observe, for example, that in 2020, there has not been any significant mobilization of resources of the global health systems for low and low middle income countries. It only arrived in 2021. And we had observed that, if you remember, already during Ebola. There was this really very spectacular data in 2014, which showed that the Ebola money reached the 3 West African countries after the epidemic was over. So that is really this questioning as to whether our system that relies on centralized funds, global centralized funds, is fit for purpose in the future. And of course, I think there are a lot of calls, and that's part of this conversation about multi-sectoral financing for bringing money closer to the beneficiaries, either by funding more directly countries or regional institutions, which is very much a demand from Africa, but also we see with East Asia, for example, with the recent creation of ACFID in ASEAN. But also within countries, the clamor we see in the climate adaptation world and social protection discussions for designing mechanisms that bring funding directly to households and to local communities, so that we as much as possible reduce the transaction cost of having going through different multitude of centralized mechanism. And I think in the case of COVAX, for example, we've seen really the limitations of having one centralized mechanism, which could just not balance the needs of all countries when they all ask for support at the same time, and that there was a sort of mix between financial needs and just procurement needs, which are 2 completely different problems, and they were mixed during the crisis, and because there was in fact never any financing problem during COVID, and actually a lot of the money that has been mobilized during the crisis is still here today unspent. But there was a major problem of 2 centralized procurement systems that led to a country like South Africa, which had money on the table to purchase vaccine, not to be able to. So that's sort of illustrations on how I think the thinking is going about rethinking global health. And when it comes to Lusaka, I think there is nothing not to like about the Lusaka agenda. And it's all very good recommendations. But this is the same as the IHP agenda, which is now 20 years old. So there seems to be a recognition by the international community that we need such an agenda. There is a lot of demand from developing countries, but we don't seem to be able to go beyond the sort of broad agreement to actually changing really the way financing is organized at global level. And it's not a lack of instruments. We have all the instruments. I mean, Mareike just was describing the kind of instruments that the Global Fund has, whether it's debt swaps or co-financing or buy down, everything is there, but it's very little used. it's very, very little used. We are in the very small amounts as compared to the global health amounts. So that's really I think that very clearly, and we had that in several working groups on the future of health financing, that there is no way we can continue to rely on an approach that is just about small amounts of money through grants and the very same instrument for all countries. That is like we give money to very poor countries with low capacity, like, I don't know, Malawi or Liberia or Guinea-Conakry, and we give it on the very same terms we give it to a country like Indonesia, which is a country with very high level of economic growth, investing massively into the health sector, and for which we really wonder whether you need the same type of instrument. So this idea of using the instruments we have much better, leveraging much better domestic financing at country level through country dialogue and social participation in country platforms, but also articulating much better the concessionality that we have in the system, and that we stop, and that's a point that is very, very dear to my heart. I'm actually, try to teach it in my activities as a professor is really that we should stop distinguishing grants from loans, like grants is perfect and loans is bad. It's all about the cost of money. And the problem is not 0 or 100. The problem is the cost of money can be 0, 0.1, 0.11, 0.2, 0, 4, 5. The question is how poor countries for whom the cost of money is very high when they try to borrow on the international market, how this cost can be minimized so that they don't pay a lot of interest and they can repay what African countries are asking, and they've done that many times, most recently in the financing summit, the new financial pact in Paris, is they want much larger amounts, much more liquidities, and over a long term. They want 30 years, 50 years terms to be able to invest. And they make the very same request for loss and damages. So the point is not about a couple of billion in grants tomorrow. The question is about trillions through different ways and different instruments over the next 10 or 20 years. It's how you rethink global financing so that the cost of money, which is again getting lower and lower for rich countries, and the interest rates are going down right now for Northern America and Europe, that these interest rates are also very low for developing countries, that they have access to amounts. And I'll finish this point with what has become recently my favorite number, which is public development banks, which are banks like the World Bank, the Asian Development Bank, us, France Agency for Development, or small banks at country level, the Rwanda National Bank or DBSA, the Development Bank of South Africa. There are a little bit more than 330 banks in the world. There are some in Pakistan, in Brazil, in China, in Vietnam. Altogether, these public development banks that lend money, that lend public money, they mobilize every year 2.3 to 2.5 trillion. Right? And this 2.3 or 2.5 trillion is just what they mobilize. So it's without going further into thinking about how we could do more blending with the private sector and more concessionality and so on. If you think 2.3, 2.5 billion, a trillion, and if only 10% of that would be allocated to maternal, child, and adolescent health, that would be 230, 250 billion, right? And in fact, most of these development banks are very far away from this 10%, very far away. In fact, many of them don't invest in health at all. And it started with the multilateral banks, the World Bank, Asian Development Bank has really increased its lending for health. But the question is, how can best local development banks also support the development of climate resilient infrastructure, of adaptive social protection system, etc. And how do we mobilize that financial capacity? And we use the amount of grant funding that we have, and that includes, the thinking that we have here in France. How do we mobilize these amounts of grant funding as a way to soften the terms at which those countries can mobilize trillions? And that's really, I think, the question. And within that, of course, it will, the whole architecture will have to evolve. And I think, if anything, we cannot just multiply the number of organizations. Some of them have been very successful, no question. The Global Fund has had tremendous success on triggering, on contributing to the increase in the treatment of people living with HIV, for example. No question about the success of Gavi in introducing new vaccines in the developing world. But it cannot be that this success can be repeated indefinitely. And I think that has been a bit the problem, this kind of almost an industry that has developed around that. Say, oh, let's create a fund, let's mobilize money. But at the end, there's only one set of donors that actually contribute to that. And there is a kind of zero sum there, particularly in today's world that is quite troubled, and in the context right now, certainly in Europe, with France and Germany being in a kind of very tight fiscal situation. Thanks.
Yeah, thank you. No, thank you very much, Agnes. And you've also answered, indirectly some of the questions that have come up in the Q&A and through the chat function as well. And really, appreciate the veracity of issues that you brought about, and particularly going back to the point about the exit dates and what we do need to do in terms of changing the global health investment architecture. Soji, over to you. Your reflections on the question and then where you would want to build upon to some of the arguments that Agnes has made in this regard.
Thanks. I'll pick up from where Agnes left off, since I always agree with everything Agnes says, especially on Tuesdays. The Lusaka agenda. Yes, it does not really say anything new. To its credit, it recognizes that it would be unwise to have more global health financing institutions. Having said that, I think the totality of it, in my understanding, is that the Lusaka Agreement reflects both a lack of imagination and a lack of courage. Let's just call a spade a spade. Because in a mind-boggling sense, it calls for incremental or marginal changes to be done within the current architecture of global health financing institutions. And when you look at the failure of global health financing institutions during COVID, for example, during the COVID pandemic, one comes to the conclusion that the Lusaka Agreement simply either did not recognize just how broken the current system is, or it recognizes how broken the current system is, but lacked the courage to call it out and go for what is needed for a better situation, a better architecture. Now, the second aspect of this is when you look back, when one looks back, you can say, with the benefit of hindsight, how might things have been done differently, and how might that realization influence what is done from now and in the future. The global health grant financing architecture, which is very romanticized by the public health fraternity and sorority, has contributed to short-term gains in health services and health outcomes. Agnes mentioned those regarding, for example, contributions of Gavi in immunization front, contribution of the global fund, for example, on tackling the HIV problem. Having said that, they collectively had at least two fundamental congenital defects. The first one is they were launched without any explicit exit date. And that's terrible because it sets up really bad behavioral incentives institutionally and also among some of the countries. A second one is they were optimizing for outcomes that affect only a very small part of what is really important to the countries. What do I mean by this? Increasingly, many countries are no longer satisfied with promises of, I'm just going to give you one more grant to buy this commodity or one more grant for those services. And they're beginning to reflect on the fact that, look, 3 years into, 3 decades into the HIV/AIDS pandemic, for example, how many of the countries or sub-regions, say in Africa, have the capacity to produce, to manufacture on their own soils the commodities that are being used to tackle HIV/AIDS? Does it really make sense in 2024 to be doing a replenishment? If the purpose is, oh, we're going to use to buy more bed nets, we're going to use to buy more of this commodity, of that commodity. If those bed nets and those diagnostics and those medicines are not being manufactured in the countries themselves, the quote unquote recipient countries, 3 decades into the problem. And so what is being done now, and I'm not saying this is with bad intentions. That is not the point. I'm not questioning anybody or any entity's intentions. That is not the point. I'm just saying that it is compounding a congenital defect by keeping the current architecture as it is and replenishing it as it is. That needs to change. A third major point is, I think we need to be a little more, it would be good to be a little more nuanced in the way one uses the phrases, financing gap and WHO resolution, et cetera, et cetera. WHO is an indispensable entity that does phenomenal work on technical leadership and norms. Having said that, when you have a WHO resolution, you essentially have a resolution by a body that does not have its own internally generated revenue to commit. Therefore, just taking that as an article of faith and saying we're not going to beat up on everybody and say raise money to fill the financing gap, it strikes me as, to be kind, overly naive. Okay? So there is nothing inherent, there's no law of Hammurabi that says if something comes from a WHO resolution, then donors must jump up and down and fund it. I mean, you've seen what happened with the recent WHO replenishment drive, the first of its kind that it tried. What does this mean? It means that there's probably greater value in focusing on how the countries, their institutions, the sub-regional institutions or regional institutions, again, to which Agnes alluded, can be enabled, can be partnered with, so they move from where they are to the next step. The next 5% coverage, for example, in whatever service delivery area we're talking about, and then the next 5% coverage on top of that, and then the next 5% increment on top of that, rather than a utopian effort to jump from where one is today to something that is dictated in a globally mandated compact, which, let's be honest with ourselves, does not usually resonate at the operational level in the countries because they were not there. It's not their compact. It's some compact manufactured in New York or Brussels or Geneva. So I think that these are not very easy discussions to have, but they must be had. And again, I close with what I closed with on the last, in the first segment, which is that the biggest burden, the biggest responsibility lies with the countries themselves, because you cannot effectively develop somebody else's country from outside. Back to you.
Thank you enormously, Suji. And indeed, uncomfortable conversations, but conversations we must have if we are going to have what I think you implored on us all to have courage and to make the meaningful change which moves beyond the rhetoric that we are confronted with. I'm doing very poorly on time management as the moderator. So a brief request to Flavia and to Marika, if they could please please keep their remarks brief so that we can get to the other segments of our conversation as well. And with that, Marika, I do want to come to you next and then ask you, so, and you've already raised a lot of issues, but what do you think are some of the key obstacles that you face in terms of different contexts? And of course, any reflections you might want to share on what you've heard so far as well. Over to you, Marika.
Thank you very much, and I really will try to keep to be brief. And let me start with Saji's last question, that ultimately it is the responsibility of countries to fund their health system. And also acknowledging that countries do have different economic capacities and different economic situation, but very much agree with that. And that is also the reason why we developed our, updated our policy for sustainability, transition, and co-financing to really support countries to work towards self-sufficiency. Because also recent, I think it's part of the Lusaka agenda, but also recent statements from African Union, the African Leaders Meeting, it's really to move towards self-sufficiency. So very supportive of that development. Also very supportive of the increasing focus on regional manufacturing. I think that would be a really good area where multilateral development banks, the public banks that Agnes talked about, could invest in, as there will be it's an investment that will deliver a return on investment. So it seems to be a no-brainer to look at it. But it also requires that there's work, and it can be led by the African Union or the African CDC, to really look at how then the region comes together and how there's alignment on regulatory mechanism, because there's no economic case for each country to produce its own commodities. It really should be a regional effort. And we are very supportive of it, but probably not and we, in our tenders, we do give additional points for manufacturers that are based in implementing countries, but we are not the best organization to push and fund that. On domestic resource mobilization, I think we have to acknowledge that a lot of the countries are in a really difficult economic situation with limited, with lots of economic constraints, with, for many countries, high levels of indebtedness. And that's usually not the debt to like the development banks that are the difficult ones, but a lot of countries have crippling debts by private lenders with very unfortunate conditions. So whatever can be done to soften some of these conditions, and there have been some interesting opportunities, mostly about biodiversity and climate on tripartite deals where involving, I don't know how you call them in financial terms, but there's so many financial people who should know that. But at least where there's a deal between a country, the one who is the countries are holding very unfavorable debts, and then another organization, which can be a bank or the US, I think it's called SCD, or development banks, that then soften the loans, which then allows additional funding to be invested in. Mostly so far, those have been around climate and biodiversity. Just a very quick point on climate, because I know we all see that there's a lot of money available for climate change and much needed. I don't think we have collectively made the case yet to use some of the climate funding to invest in the mitigation of the health impact. What I've seen that most of the discussion is really about looking at the health sector as a contributor to climate change and how we can limit the carbon footprint of the health sector, which is an important thing. But I think we need to have a serious conversation on how some of the climate funding can support the mitigation of the impact of climate on the health of especially the most marginalized populations. I hope that's brief enough, Rajat.
Thank you, Marika, and also bearing with the shortness of time. Flavia, over to you. And anything, actually, your reflections on what you've heard, but you started a conversation about different approaches that we need to consider to integrate women, children, and adolescent health. So very much looking forward to hearing from you. And then hopefully we can hear the reflections from the Deputy Minister, Sierra Leone, before coming to other remarks momentarily. Flavia, over to you. You're on mute, Flavia. We cannot hear you.
Thank you. Thank you very much, Rajat and colleagues for the points. I'd like to make 2 additional points very briefly. Number one, and yes, you quoted the number that you are most interested with, that is the sum of the overall development bank mobilization of resources. I think it would be very wise if PMNCH would do an analysis of that mobilization for what it concerns women, children, and adolescent health, to expose, as you said, how much or how little many of these development bank invest. This is my first point, Rajat. Maybe for the 2025 program work of PMNCH, something that would be very useful. My second point is to build on what Marika was starting with, and I also alluded, and to make a plea that we move from the siloed financing for health, which we have had, to a more horizontal and intersectoral financing, and especially that we look at the co-financing option that the climate change and the climate financing afford. So on this point, this financing will have impact both at the domestic level, but also internationally for the instruments that are currently existing for addressing climate change. So domestically, for example, looking at intersectoral adaptive social protection measures, like in the case of drought, for example, what Kenya has done in the case of drought has used social protection schemes and cash transfer distributed for enabling accesses to health services during drought. But also looking at what the revenue that countries can make using, for example, carbon pricing, carbon taxes, or simply stopping the fossil fuel subsidies, which are estimated globally to be around 7 trillion per year. For example, one country like Switzerland has used the revenues for carbon levy to help reduce the healthcare insurance premium for its citizens. So these are all measures that countries could do to look at the domestic revenue. Then there is the large, Agnes mentioned it, the large infrastructure that currently exists, and there are some opportunity I see there. In particular, the Green Climate Fund has opened a window for health adaptation, and so far only few countries, with the help of Save the Children, were able to leverage resources in order to address women, children, and little adolescent adaptation needs in response to climate change. This has been limited now, for example, for the experience of Laos and Malawi, but we could learn from those experiences and share with other countries and build further, especially as there are also discussions that these could become regional instruments. And then finally, maybe we could also learn from the climate financing world in the way that they have begun to leverage private sector investments, because this, the way I see it, Rajat, and Agnes mentioned that the ODA investments, given the geopolitics and the condition we're living in, is not likely to increase. So in order to sustain financing, we need to look at the mobilization of private capital. And for example, one last thing I'd like to mention is that the Climate Investment Fund, just at the COP29 in Baku last month, they launched a so-called capital market mechanism, actually in the London Stock Exchange, that is to leverage private sector investments for their resource mobilization that are then address, for example, areas like clean technology and mobilization of moving from fossil fuels in countries. Let me stop there and thank you so much. This has been extremely stimulating and rich, and I hope we can capture it.
Absolutely. Thank you. Thank you very much, Flavia. Now I have the impossible job because we have about 14 minutes on the clock remaining and about 5 more speakers wanting to go. So I'm going to do something which I hope people will forgive me for that. I do want to hear from constituency representatives, and we do have the head of Global Financing Facility, Luke, and some closing remarks from Mark. Just requesting you all to try and keep it brief. We will want to hear from you all. You have been patiently listening. There's been a very rich conversation, and I will shut up myself now. But first, over to you, Minister, for your brief reflections, if you can, to share with us. Thank you.
Thank you again, Rajat, and I do apologize for the many technical issues it appears we're facing from Sierra Leone today. I hope it's better now. You can hear me better. And again, to everybody, I mean, I was supposed to frame the conversation at the start, not go after all these amazing speakers, unfortunately for me. So bear with me if I sound a bit unremarkable after everything you've had. I will give it in the form of a reflection rather than a keynote. And then, I mean, greetings from Sierra Leone, from the minister who would have loved to be here. For us in Sierra Leone, I mean, using our experience, we see, just like the rest of the world, that we've made a lot of progress in maternal and child health. But again, the reality is we're still losing many, many women every day from pregnancy and childbirth, and we're losing children and adolescents from conditions that we know how to treat. And I mean, all of this is threatening the future of our communities and our country. And one thing we've also seen, again, which is relevant to this discussion, is that financing and resources are a big part of what we need for some of the transformational change that we're hoping to do. So how do we make the case for this kind of investment? We've heard from Rajat that for every dollar we spend in maternal and child health, we have a return of about $20 in economic returns. And for us in Sierra Leone, what we've been saying to, especially the rest of the government, is to see spending on health not as an expenditure, but as an investment in national development. So we know that when we have healthy women, healthy adolescents, and healthy children, it leads to stable families and resilient communities. And that's why we're saying this is when and now to invest in healthcare. How do we achieve this transformational change in our countries, in a place like Sierra Leone? I would follow on some of the things that Olusoji spoke about. So first of all, the importance of domestic resource mobilization and how our own governments have to take responsibilities for some of this domestic funding, especially for health. So prioritizing health spending in our budget with an explicit focus on equity. The other thing, of course, is optimizing our resources, existing resources. So what also just termed as, I would say, disciplined resource allocation and disciplined spending, because in a place like ours where we have budget constraints, we need to become more efficient at how we spend our funding to ensure we have significant impact. So strengthening our already existing health systems and health budgets, streamlining budgets, streamlining supply chains, exploring, local or at least regional manufacturing of life-saving commodities, procuring from neighboring or regional countries as opposed to, procuring from countries further away where all of these add up to the cost, and scaling up cost-effective interventions. I think these are some of the things that are pivotal in terms of optimizing our existing resources. And then, of course, leveraging innovative financing mechanisms. I think we've had talking about targeted taxation. Here we're exploring debt swaps for health and even blended finance, and definitely partnership with the private sector. So the other thing we're saying is making sure these resources that are generated or that are optimized actually reach the most vulnerable members of the population. So our women, our girls, our adolescents, people in marginalized communities, people in conflict zones, people in the rural areas, because these are where the greatest inequities lie. So we have to be deliberate with these efforts. We have to ensure we think about having gender responsive budgeting. We make sure that it's participatory, it's inclusive, and that it places women, children, and adolescents in the center of the decision-making tables. Again, we recognize that, yes, domestic financing is key. It is important. It's the way to go. But also, because of economic situations in many of our countries, we still need global contributions towards this finance, and this is indispensable. How do we maximize this? We make sure our donor funding align with national priorities. And I think we've had many of the speakers talk about how this has to be intentional. So that, 1 year from the launch of the Lusaka agenda, or 20 years from the launch of IHP, we're not still talking about this. So these resources, when they come in, they should be focused to strengthen country systems. They should use country instruments whilst building sustainability plans in right from the start. And they should help our countries to strengthen our primary health systems and build adaptive social protection schemes. For us in Sierra Leone, we've seen firsthand how when we have targeted investments and high impact interventions, how they can drive meaningful progress. For example, in the area of maternal mortality, this is one thing we're very proud of, where we've made a remarkable 60% reduction in maternal mortality over recent years. And this has been through, yes, domestic financing, strategic partnerships, and also with many of our traditional partners moving away from vertical approaches towards, multi-sectoral approaches, and also working through country instruments to build and strengthen the country health systems. So despite ongoing challenges, these efforts have shown that, financing, when it's done the right way, it can be a catalyst for equity and lasting change. So now we're also trying to build on these successes for maternal mortality and do the same for child health and adolescent health, areas where we've not, invested as much as we have done in maternal health. And one thing I would just want to end with is to, call on all of us here today. I don't want to take this as a call to action, but rather just an encouragement for us to continue this kind of dialogue, and also to focus on countries, on building country systems, strengthening our own accountability systems, yes, in the countries, but also accountability systems for the partners as well and the donors that are working in this country, so that there's mutual accountability towards delivering the promises that we've made towards strengthening women, child, and adolescent health. Thank you.
Thank you, Minister, for those remarks and also bearing with us for time. Unfortunately, we are running out of time. So interventions from floor that we had from our private sector representatives, from healthcare professionals and AY, I would like to request them to please put them in the chat so that we can hear your reflections as part of the substantive dialogue on this conversation. And apologies to you, Karen, Jacob, and Olonji as well. And with that, I would indeed like to move on to the last segment of our discussion today and come to you, Luc Labilot. For those of you who don't know him, he's the head of the Secretariat for Global Financing Facility, for your reflections for what you have heard, and also to you, Mark, Mark Hansen, the Professor Emeritus with the University of Southampton and co-chair for the PMNCH Evidence and Accountability Working Group. To you first, Luke. Over.
Thanks, Rajat. It's been really great to listen into this panel. First, I really like the title of Ready, Set, Implement, not only because it's punchy, but because it really is focused on the how. You know, we've talked for years on the why and make the economic argument, etc. We've also talked a lot about the what, but we know what works, as we've heard in this session. There's a lot of, you know, devil in the details of the how, and I'm very pleased to come right after Dr. Mustafa, because quite frankly, as a country-driven model, Dr. Mustafa, you've just said everything that I wanted to say. So I just want to fully endorse everything you just said, and just maybe emphasize the importance of working with countries such as Sierra Leone on your own national plans and helping you, you know, to the extent that we can, with the discipline that Soji mentioned on, you know, through the prioritization process, the knowledge, etc. But also, you know, encouraging everyone in country to come together around a platform and use all the instruments in the toolbox. We heard about the various sectors that can contribute to advancing the health and nutrition well-being of women, children, adolescents. I don't think we're actually fully maximizing as we heard, the use of these different parts of the toolbox. But I also wanted to emphasize that we're not, and with the caveat that Soji made about the realism of scale, I think that focus on scale with equity is really critical. And we sometimes tend to come to a table with, this is how much money I have and how much, you know, what can we do with it, as opposed to what we try to, you know, what we work with countries on, which is start with the national plan, where you're at, and see what scale is required to have the impact, and then work backwards in terms of what financing is needed. And in our case, there's always financing for the plan, and maximizing that. So it's not a planning exercise in theory. It's actually with financing that always comes at a minimum from the World Bank project that we co-finance. We currently have a ratio of, for every $1 of grant funding from the Global Financing Facility, there's at least $7 to $8 of World Bank financing, and increasingly other financing crowded in. So I wanted to emphasize this point about that national process, including a range of other actors in the country for scale and for equity, but also the importance of looking at positive outliers and learning from them. And Sierra Leone is a very good case of that. But there are others actually, such as Somalia, for example, where we see much more rapid than average improvements, and looking at that, learning from it and rapidly sharing between countries is something we try to support as much as possible. We've heard today about the need to differentiate between, I think it was Agnes who spoke about how we tend to look at financing in the same way in Indonesia as we do with, you know, lower capacity countries. There's a group of countries, of fragile and conflict affected countries, I think that we need to pay particular attention of. Unfortunately, it's not a category of countries that's getting smaller, but and so we need to, I think, pay particular attention. And then maybe just a final point on, we've spoken a lot about financing. This was the topic of the discussion today. It's really critical. Underlying financing is also is knowledge, and we're finding in the countries that we work with that that sort of ability to access rapidly knowledge either through their own systems, so just-in-time data, ability to respond quickly to what the systems are telling them, but also the global knowledge or the knowledge from peer countries is really critical. And in that and in many other respects, really kudos to PMNCH on that front. Thanks, Rajat.
Thank you for that, Luke, and really appreciate you joining us early in the morning. Mark, over to you for final reflections, please.
Thank you very much indeed, Rajat. Colleagues, I think this has been a wonderfully rich dialogue, and it gives us some fantastic ideas to take away as we think about the next steps for the partnership. Of course, the role of PMNCH is to translate evidence into advocacy for greater investments. And so just to make 2 or 3 very brief points of things that have or haven't been mentioned. We obviously need to move from the global to the local level. And one thing I wanted to flag was that with the London School of Hygiene and Tropical Medicine and the Campbell collaboration, we've launched the most extensive yet economic and financial evaluation of interventions in low and middle income countries in the form of a scoping review and evidence gap map. So this was looking at 732 studies, and it provides an online searchable resource for policymakers and others at the level of countries, interventions, life stages, and the type of economic evaluation. So please have a look at that. We've clearly, all of us feel that we need to work much more at the intersection between climate change and health. We published a couple of papers on that this year, but there's clearly, Rajat, considerably more to do there. Likewise, I think we need to think carefully about working with private sector organizations, and as Agnes first said, with local investment banks, and thinking about how we might control and avoid conflicts of interest in that setting. We need to engage with young people to see how they will help us in this agenda. And I think in PMNCH, we can build on the substantial support that we derived from the 1.25 million adolescents who responded to our What Young People Want campaign. And one of the focuses that they were particularly strong on was education and skills. So I think that gives us a way forward. And last but not least, I think we need to find ways to provide the knowledge and skills that local NGOs need, as some of them tell us that they lack the support and resources that they need to influence policymakers, whether it's in elected government officials or parliamentarians more generally, especially, of course, in the context of social inequalities. So I could say much more, but I'm going to stop there and hand over to you, Rajat, to close what I think has been a fantastic dialogue. Thank you.
Thank you. Thank you so much for that, Mark. And thank you enormously for guiding our work in this area. You know, your support, your leadership has been enormous as the chair for the Evidence and Accountability Working Group. Colleagues, we come to an end of our conversation today, and sincere thanks to all the panelists and the speakers, and apologies to any questions that we did not come to, and for our friends and colleagues from PMNCH constituencies who have shared very rich reflections on the floor. Apologies we could not come to you for in-person interventions. But this is, as the conversation showed, a dialogue that we need to have with each other. Uncomfortable, to take Dr. Soji's remarks, an uncomfortable conversation to have, but we do have the deep desire to innovate, and the fact that this is doable. This is something that we can innovate and get to. There were some very clear ideas and reflections in very challenging times that have been shared by the panelists from their experiences working in these areas in different settings. Thank you so much. As the title of this series says, Ready, Set, Implement. This is the last one for us for 2024. We will be coming back to you with the new series of Ready, Set, Implement in 2025. From all of us at the Partnership for Maternal, Newborn and Child Health, thank you for joining us, and season's greetings to you all for the end of the year. Thank you. Have a good day.
Thank you very much, everyone.
Thank you. Thank you, everyone.
Thank you.
Rajat.
Thanks. Bye-bye.
Thank you very much.
Thank you. Bye. Bye.